Hello, everyone. Welcome to the Green Top Guidelines Summaries of the Day. The management of nausea and vomiting of pregnancy and hyperemesis gravidarum, the Green Top Guidelines 69, published in June, year 2016. Nausea vomiting of pregnancy is defined as the symptom of nausea vomiting during early pregnancy where there are no other causes. The hyperemesis gravidarum is the severe form of nausea vomiting of pregnancy, which affects about 0.3 to 3.6% of pregnant women. The aim of this guideline is to provide evidence-based or best clinical practice information regarding the diagnosis and subsequent management of nausea vomiting of pregnancy and hyperemesis gravidarum. There is variation in the management of women who have nausea and vomiting of pregnancy or hyperemesis gravidarum, with an occasional lack of understanding of its severity and options for treatment and support. The nausea vomiting of pregnancy affects up to 80% of pregnant women and is one of the most common indications for hospital admission among pregnant women, with typical stays between 3 and 4 days. Nausea vomiting of pregnancy should only be diagnosed when onset is in the first trimester of pregnancy and other causes of nausea and vomiting have been excluded. The hyperemesis gravidarum can be diagnosed when there is protracted nausea vomiting of pregnancy with a diet of more than 5% pre-pregnancy weight loss, dehydration, and electrolyte imbalance. An objective and validated index of nausea and vomiting, such as the pregnancy unique quantification of emesis score, can be used to classify the severity of nausea vomiting and pregnancy. The clinicians should be aware of the features in history, examination, and investigation that allows nausea vomiting of pregnancy and hyperemesis gravidarum to be assessed and diagnosed for the severity to be monitored. Other pathological causes should be excluded by clinical history or focused examination and investigation. A very important table of this Green Top Guideline, Table 1, with the features in the history, examination, and investigation. The question in the differential diagnosis tends to come what investigations are going to be sent in EMQ for your exam. The women with mild nausea vomiting of pregnancy should be managed in the community with antiemetics, and ambulatory daycare is also available. However, the ones with the continued nausea vomiting and inability to keep down the oral antiemetics, they must get admitted, along with those who have the risk factors like ketonuria and the weight loss as well. The pregnancy unique quantification of emesis that gives us a score of around 24, in which mild is 6 and less, moderate is 7 to 12, and severe is 13 to 15. There are safety and efficacy data for first-line antiemetics such as antihistamines and phenothiazines, and they should be prescribed when required for nausea vomiting of pregnancy and hyperemesis gravidarum. Women should be asked about previous adverse reactions to antiemetic therapies. Drug-induced extrapyramidal symptoms and oculogyric crisis can occur with the use of phenothiazines and metoclopramide. If this occurs, there should be prompt cessation of the medications. Metoclopramide is safe and effective, but because of the risk of the extrapyramidal effects, it should be used as second-line therapy. There is evidence that ondansetron is safe and effective, but because data is limited, it should be used as second-line therapy. Diazepam is not recommended for the management of nausea vomiting of pregnancy or hyperemesis gravidarum, and the normal saline with additional potassium chloride in each bag with administration guided by daily monitoring of electrolytes is the most appropriate intravenous hydration. The Appendix 3 recommended antiemetic therapies and dosages are the first line, the second line, and the third line come sequentially in the extended match question. Please keep a note, this Green Top Guideline is different from the Irish recommendations. For my students who are doing MRCPI written in the OSCE, they've got different recommendations for this guideline. Ginger may be used by women wishing to avoid antiemetic therapies and mild to moderate nausea vomiting of pregnancy. Women may be reassured that acustimulations are safe in pregnancy, and acupressure may improve the nausea vomiting of pregnancy. Urea and serum electrolyte levels should be checked daily in women requiring intravenous fluids. histamine receptor antagonists or proton pump inhibitors may be used for women developing gastroesophageal reflux disease, esophagitis, or gastritis. Thiamine supplementation should be given to all women admitted with prolonged vomiting, especially before administration of dextrose or parenteral nutrition. Women admitted with hyperemesis gravidarum should be offered thromboprophylaxis with low molecular weight heparin unless there are specific contraindications such as active bleeding. Thromboprophylaxis can be discontinued upon discharge. In women with severe nausea vomiting of pregnancy or hyperemesis gravidarum, input may be required from other professionals such as midwives, nurses, dietitians, pharmacists, endocrinologists, nutritionists, and gastroenterologists, and a mental health team, including a psychiatrist. When all other medical therapies have failed, enteral or parenteral treatment should be considered with a multidisciplinary approach, and all therapeutic measures should have been tried before offering determination of a wanted pregnancy. Women with nausea vomiting of pregnancy and hyperemesis gravidarum should have an individualized management place and discharged from the hospital. They also should have the continued symptom check. If at all it is in the late second or the third trimester, they must be having serial scans for the fetal growth check as well. They do have a recurrence risk in the future pregnancies. Early use of lifestyle dietary modifications, antiemetics, practitioners should validate the women's physical symptoms and the psychological distress. A woman's quality of life can be adversely affected by nausea vomiting of pregnancy and hyperemesis gravidarum, and practitioners should address the severity of a woman's symptoms in relation to her quality of life and social situation. The treatment algorithm for nausea vomiting of pregnancy and the hyperemesis gravidarum is a must extended match question for your exam. So the important exam points from the hyperemesis gravidarum are the history and the investigation points, the management plan, and the drug's pharmacological treatment in a stepwise manner. Best of luck from the entire team of RFA Tutors. I thank you all for being with us today. See you next time until we meet again. Take very good care of yourself. Bye-bye.